Connective tissue is also really important when we consider the musculoskeletal system. And we know that there are two types of collagen in our connective tissues. We know that there's type 1, and those are the thick, rugged ones that really don't move when they're stretched. Whereas there's type 2, and they're thinner, and they are better at providing a framework. So tendons and ligaments are pretty similar. They have a similar histological makeup. They're both made of dense fibrous connective tissue, primarily type 1 collagen. And the collagen fibers are oriented in a parallel fashion. And this is important because when we think of the purpose of tendon and ligaments, that parallel collagen alignment allows them to have good tensile strength and structure. When we think of the histology, we know that there are fibroblasts between the collagen, and fibroblasts can become fibrocytes due to decreased activity in adult life, and that results in minimal blood supply. So there's actually a change in our blood supply as we age. The attachments, we know that there's a continuation of collagen fibers into the substance of bone, and we know these as Sharpie's fibers. So when we think about a tendon or ligament being avulsed from bone, sometimes the tendon and ligament can come right away from the bone, but typically because of that significant attachment into the cortical bone, there can be a bony avulsion as well. There are a few important parts of a tendon specifically that we should consider. We know that there's a tenoperiosteal junction, or where the tendon attaches to the bone, and we already talked about the Sharpie's fibers that are at that location. And then there's also a musculotendinous junction where the muscle attaches to the tendon, right? Different injuries can occur at those different sites, so we want to be able to differentiate between those two. We also know that there's a synovial sheath that surrounds tendons, and that helps to decrease friction. So if you think of a tendon as a rope that is attached to a rock, and it's moving around that rock regularly, that rope would start to fray, right? So we have this synovial sheath that not only allows our system to be more functional and energy to be conserved by decreasing friction, but it also helps to protect that tendon. Okay, that synovial sheath surrounds the tendon and is filled with fluid to allow the tendon to glide more easily. So sometimes when we talk about tendinous injuries, we're talking about an injury to the tendon itself within the sheath, and sometimes we're talking about an injury that occurs that encompasses the sheath as well. Ligaments are a little bit different from tendons in that the fibers do not always align with the direction of the tissue. So when we consider the ACL, for example, it not only resists anterior translation because of its orientation, but it's twisted around. The fibers of the ligament are twisted around. And so because of that, if you think of a string attaching two bones and you just pull it in one direction, it's going to resist that motion. But if you also take a string and twist it around, if you untwist that string, it will eventually stop as well. So the spirally wound orientation of the fibers in the ACL allow for the ACL to not only resist anterior translation, but also rotation of the tibia medially. So it's important to consider that ligament fiber alignment does not necessarily align with the tissue, but it does align with the direction of the motion that the ligament is intended to resist. So when talking about joints, we know that there are a few ways to classify a joint. If you guys remember, the synarthrosis is a joint that allows essentially no movement, right? So it's fibrous or cartilaginous, whereas diarthrodial joints or synovial joints allow moderate to extensive motion. So these joints allow movement, but it's important to remember that they allow movement at the expense of stability, so they're not very stable joints. A synovial joint is what we are going to spend some time talking about, and it's important to think about the different aspects of a synovial joint. So a synovial joint consists of the two bones, right? And they are covered by articular cartilage. Sometimes there is something in between the two bones, like a disc or a labrum, and those bones are surrounded by a capsule that contains synovial fluid. So let's talk about the capsule. Capsule is always kind of a mystery to students, and so hopefully we can clarify it a little bit. So a capsule actually consists of two layers. There's the internal one that is the thin synovial membrane, and that is the one that keeps the fluid, the synovial fluid, in the joint. And then there's this external or thick fibrous layer. And that part of the capsule is the part of the capsule where ligaments can actually blend into. So we know that the MCL, for example, kind of blends into our knee capsule. And the other thing that we know about the orientation of the fibrous alignment of the external layer of the capsule is that it is also made of collagen, but the collagen is not aligned in parallel as our ligaments or tendons. So they don't give kind of an abrupt stop to motion like a ligament would if you pulled on someone's knee. The capsule is aligned kind of in a haphazard way. So there's a non-parallel orientation of capsule. So that allows it to also resist motion, this external fibrous layer, but it's not as abrupt as a ligament. So when we think of the synovial fluid that is present within the internal layer of the capsule, we know that that fluid nourishes the articular cartilage and lubricates our joint surfaces, right? That's the stuff that if people have an injection in their knee for degeneration of their knee, they are basically injecting a type of fluid that mimics synovial fluid to allow for lubrication of the joint. Another important thing to know about synovial fluid is that it does not contain fibrinogen. So there's no clotting that occurs within synovial fluid. So let's think about some joints that contain tissues that may need clotting for healing. If they are present within the internal layer of a capsule, because of the presence of the synovial fluid, they will likely not be able to heal. There are two types of cartilage that we want to be aware of when considering a synovial joint. There's the articular cartilage that covers the ends of the bones, the articulating surfaces of the bones, and then there's fibrocartilage, and that is the type of cartilage that makes up any type of disc or meniscus within the joint space. So articular cartilage is present at load-bearing surfaces of joints, and the benefit is that it distributes and absorbs joint forces and reduces joint friction. We know that it is primarily made up of type 2 collagen, and it's actually mostly water. And that helps to allow for the deformation and the ability to absorb those joint forces. When we think about injury to articular cartilage, we know that there are some things that we need to consider when thinking about how it's going to heal. So articular cartilage is avascular and it's also aneural. So if you injure your articular cartilage, you're not likely to feel it. And it's avascular, so it doesn't really heal well. More importantly, it doesn't have a perichondrium. And a perichondrium covers most cartilage, and it contains the blood vessels and primitive cells, so that allows most cartilage to rejuvenate and heal itself. But because articular cartilage does not contain pericardium, it is not really capable of healing. So if there's normal wear and tear, it's capable of normal maintenance and replenishes its matrix just through chondrocytes. But if there's any type of significant damage, especially to adult cartilage, it's often repaired very poorly or not at all. Conversely, fibrocartilage, as we mentioned, makes up the discs that we have in our body. And fibrocartilage is made of dense bundles of type 1 collagen. And again, it's type 1 collagen similar to the external layer of the capsule that we talked about that travels in many different directions. So it doesn't have that strong linear resistance as ligaments do, but it has general resistance in multiple directions. We know that fibrocartilage is in our body to support and stabilize our joints. It also helps to absorb shock. And fibrocartilage, unlike articular cartilage, does have a perichondrium. And again, that contains the blood vessels that it needs to heal. But the thing to remember about fibrocartilage is that the perichondrium is only in the outer rim. So that has implications when we think about the location of an injury. And it's mostly aneural, as was articular cartilage. So again, you will likely not feel an injury to your fibrocartilage. And it obtains nourishment through movement. So movement promotes the dispersion of the synovial fluid. So similarly to articular cartilage, fibrocartilage also likes movement for healing. One specific type of fibrocartilage that we should consider is the intervertebral disc, because the arrangement and orientation is a little different, and we are going to be discussing some pathology to disc. So we know that a spinal disc contains a nucleus pulposus that is 70 to 90% water, and it's a randomly oriented network of type 2 collagen. The annulus fibrosus, on the other hand, is type 1 collagen, so it's more firm and it gives the structure to the disc. There are also cartilaginous end plates, and these are a thin layer of hyaline cartilage, and they serve as the interface between the bone, vertebral body, and the disc. So to review our questions, we looked at what the musculoskeletal system does for us. We talked about some of the mechanical functions and the physiological functions. We also reviewed a few tissues in the musculoskeletal system and some of the unique characteristics for each of the tissue that impact injury. And when thinking about these in review, I want you guys to consider the collagen type and orientation of the tissue, what the tissue actually does. Does it have a blood and nerve supply? Because that is also going to impact the patient presentation and how we are going to treat these patients. All right, so if you guys have any questions, we are going to discuss them in class the next time that we meet, which, you know, hopefully will be next week, unless we get another foot of snow, which we don't really need right now. So hopefully this was helpful to at least have an audio recording. I hope it wasn't the most boring thing that's ever happened to you. And I hope the quality of it was okay. Because we missed class and we are also now going to be a bit behind on quizzes, I am going to post an assignment on Blackboard that is related to this PowerPoint. And it was an assignment that we were going to do in a slightly different format in class. And hopefully this assignment will help you guys to think about the reason that we even talked about the musculoskeletal system in this way. And hopefully it will help you guys to prepare for the next quiz that we have.